Here is something that does not get said enough. Canada, one of the most celebrated multicultural countries in the world, Black individuals seeking mental health support are more likely to be misdiagnosed, more likely to be overmedicated, more likely to enter the mental health system through a police encounter rather than a doctor's referral, and less likely to receive the kind of culturally competent care that actually leads to recovery. This is not opinion. This is documented research, and it is happening right now to real families, in real communities, in cities across this country. Today, I want to talk about why, and most importantly, what we are going to do about it. My name is Esther Mark, and I'm the founder of the Philip Support Foundation, a nonprofit mental health organization supporting Black and African families navigating schizophrenia and related mental health conditions in Canada. One of the questions I am asked most often is, why focus specifically on Black communities? Why not just mental health for everyone? It is a fair question, and today I want to answer it fully because the answer matters enormously for how we respond to the mental health crisis in our community. I want to tell you about a mother. I'll call her Nkechi. Nkechi immigrated to Canada from Nigeria in 2004. She worked for 20 years as a healthcare aide, taking care of other people's families while building a life for her own. Our son Marcus was born here. He grew up speaking both English and Yoruba, navigating two cultures with the fluency of a generation that belongs fully to both and sometimes to neither. When Marcus began showing signs of psychosis at 19, the withdrawal, the fear, the beliefs that something was being done to him, Nkechi called their family doctor. The doctor referred them to a walk-in mental health clinic. At the clinic, Marcus was assessed by a clinician who spent 40 minutes with him and sent them home with a prescription and a referral to a psychiatrist with a 6-month wait. In those 6 months, with no therapy, no family support, no education about what was happening to our son, Nkechi did what she knew how to do. She prayed. She called her pastor. She told her siblings in Nigeria who advised her that Marcus needed deliverance. She did not sleep properly for 4 months. When Marcus's behavior escalated, when he left the house at 2 a.m., convinced that someone was following him, a neighbor called the police. Marcus was not violent. He was confused and frightened. But the encounter that followed, the handcuffs, the patrol car, the hours in a holding cell before a crisis worker arrived, that traumatized both Marcus and Nkechi in ways that deepened their distrust of every system designed to help them. That is not an exceptional story. It is a pattern, and it needs to end. Let me give you the research behind what I'm describing. Multiple studies in both Canada and the UK, countries with comparable Black diaspora demographics, have found that Black individuals are significantly more likely to be diagnosed with schizophrenia than their white counterparts, even when presenting with identical symptoms. This is not because Black people are more prone to schizophrenia. The genetic and neurological risk factors for schizophrenia do not differ significantly by race. The disparity is driven by clinician bias, by cultural misinterpretation of behaviors, expressions of distress, and communication styles that differ from the white European norm against which most psychiatric diagnostic tools were historically calibrated. Black individuals in Canada are more likely to enter the mental health system through involuntary pathways, through police contacts, emergency departments, and court orders, than through voluntary pathways like family doctor referrals or self-referral to therapy. This matters enormously because involuntary entry into the mental health system is associated with worse outcomes, lower engagements with ongoing care, and deeper mistrust of clinical services. Black Canadians are less likely to have a regular family doctor than the general population, meaning they are less likely to have the primary care relationship that facilitates early mental health intervention. They are more likely to live in urban areas with higher rates of structural disadvantage, which is itself a risk factor for the development of psychotic disorders. They are less likely to access private therapy, not because they do not want it, but because the cost barrier is significant and the cultural competence of available practitioners is often limited. The result of all these factors combined is a community that is simultaneously more exposed to mental health risk factors, less well served by the systems that are designed to address them, and less likely to receive timely and appropriate care when illness does develop. That is the problem the Philip Support Foundation was built to address. I want to add something to the clinical picture, something that does not show up in research papers, but that every Black family navigating mental illness will recognize immediately. When Nkechi's son was struggling, when the system failed to provide timely culturally competent care, where did she turn? She turned to the same community that had sustained her family through every other hard season: our church, our extended family, our cultural network. And those communities, despite their limitations in addressing a clinical brain condition, they gave us something. They gave us something that the mental health system did not. They gave her belonging. They gave her people who sat with her at 11 p.m. when she was frightened. They gave her a framework, however incompetent, for making sense of something that felt completely senseless. This is why I'm not interested in an approach to mental health that asks Black families to choose between their cultural community and clinical care. That is a false choice. And it is a choice that has driven too many people away from both. What Black families need and what the Philip Support Foundation is trying to build is a bridge. A bridge between the warmth and belonging of community and the evidence-based effectiveness of clinical care. A bridge that is built by people who understand both sides, who can speak the language of the clinic and the language of the community, who can sit in a church fellowship hall and talk about dopamine in a way that does not feel like an insult to faith, and who can sit in a clinical office and advocate for a patient whose cultural background is being misread. That is the specific work, and it is needed urgently. What can Black families do right now within the system as it exists? First, document everything. When you seek mental health support for a family member, keep records of every appointment, every referral, every prescription. If you feel your family member is being misunderstood or misdiagnosed, ask questions, request a second opinion. You're entitled to advocate within the system. Second, seek culturally competent care wherever possible. Ask explicitly whether practitioners have experience working with Black and African clients. It is a fair question because the answer matters. Third, access community organizations like the Philip Support Foundation that exist specifically to bridge this gap. We can help you navigate the system, understand what your family member's diagnosis means, and find the right support faster than you would find it alone. Fourth, talk to your community. The single most powerful thing any Black family can do to change the landscape for the family that comes after them is talk openly about their experience, not to perform vulnerability, but to normalize the conversation. Every time someone in our community says, "My family dealt with this and here is what we learned," they have shortened the journey for the next family. And fifth, Believe that you and your family deserve the same quality of care as anyone else because you do. Full stop. I want to end this video by saying something I believe with everything I have. The disparities I have described today are real. The failures of the system are real. The particular burden that Black families carry in navigating mental illness in this country is real. And none of it is permanent. Systems change when communities demand it. Cultures shift when families break their silence. Outcomes improve when people have access to the right information at the right time. Nkechi's story did not end with that police encounter. After connecting with community support and finally accessing a culturally competent clinician, Marcus received a proper diagnosis and a treatment plan that worked. He's currently stable and living at home. Nkechi is in therapy for the first time in her life. She's walking through her own grief, her own trauma, and building the language she wishes she had had years ago. That is what is possible. That is what we are working towards. And every family that finds its way to support is proof that the work matters. If this video helped you understand something about why the PSF exists and why this specific focus matters, please share it. Put it in front of policymakers, community leaders, pastors, doctors, and neighbors who need to understand the landscape Black families are navigating. Subscribe to this channel. Follow us on Instagram at support_PSF and visit us at www.thepsf.ca for direct support, resources, and the ability to book a session with one of our practitioners. You deserve care that sees you, and we are committed to making sure you find it.